Hello and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. In the episode of Cracking Addiction today, we're going to follow on from our earlier episode on MDMA and talk about MDMA intoxication, harm reduction, and some withdrawal management strategies. So Fergal, can you tell me about some of the mortality risks associated with MDMA?
So, as we've said before, it is a stimulant. And it causes it can cause extreme hyperthermia, which is an elevated temperature of the body. It can cause reuptake inhibition of monoamines, especially around the heart, which then can cause vasospasm, ischemic heart disease, cardiac arrest. It can cause serotonin syndrome. So untreated, that can cause, again, that can contribute to the hyperthermia. It can also cause disseminated intravascular coagulation and rhabdomyolysis, and that can occur as a result of the hyperthermia. It can cause seizures and status epilepticus and multiple organ failure. So really, at the pointy end of harms for ecstasy, it can cause death by a wide variety of mechanisms. That then brings us to the point about, well, is there a defined level of lethality? Is there a concentration of ecstasy beyond which you're more likely to die? What would you say to that, Philippe?
I don't think there's a definite fatal blood concentration for MDMA. And usually, I think a lot of the deaths where methamphetamine has been associated with, it's usually a polydrug combination of drugs. So MDMA may be a contributor, but there's usually many other drugs per se that are associated with MDMA-related deaths. Is that your understanding as well, Fergal?
Yeah, and also let's just remember that it is entirely possible to die after the ingestion of one MDMA tablet, and that's usually in young women as a result of hyponatremia and brain swelling. Mm-hmm. But yeah, you're right. Polypharmacy increases the likelihood of toxicity at lower doses. And let's just imagine that remember that the usual dose is about 100 milligrams. You start getting side effects at about 120 milligrams. I've read somewhere that probably the lethal dose might be around the 1800 milligram mark. But again, I think that number then belies the potential risks for death after one pill that is unfortunately associated with ecstasy.
So Fergal, we've just talked about the mortality risks and some of the harms related with MDMA. Can you talk to us about some of the harm reduction interventions we can use for MDMA?
Yeah, so I think it all boils down to, firstly, hydration. You don't want to get overhydrated or dehydrated. So if you're dancing in a hot environment, in a rave party, for instance, then no more than a pint of water an hour, which is about half a litre. And if you're not dancing, no more than a quarter of a litre, which is about half a pint. So it's important to drink the right amount of water. Don't get overhydrated, don't get dehydrated. It's also important to understand that really, if you're going to take ecstasy, you shouldn't actually mix it with other drugs, because remember, as we've already said, mixing other drugs with ecstasy increases the toxicity of ecstasy and the potential for harm and the potential for death. You should also be aware of the potential for serotonin syndrome. So especially if you're on antidepressants, you're going to be more likely to experience serotonin syndrome as a result of taking even one ecstasy pill. And remember, serotonin syndrome can be characterized by a triad of phenomena. We have cognitive phenomena, we have neuromuscular phenomena, and we have autonomic phenomena. So the cognitive phenomena are confusion, agitation. The neuromuscular phenomena are rigidity, tremor, hyperexcitability, or hyperreflexia. And the autonomic phenomena are elevated heart rate, blood pressure, temperature. Again, this is the hyperthermia. So that's a very easy way of conceptualizing what serotonin syndrome is, but just be aware, if you're taking antidepressants, or for that matter, any other serotonergic drug, but especially antidepressants, you run the risk of this syndrome. And I think really, if we can give a message to viewers, if you're with someone in a rave and they've taken a pill and they look red, hot, or rigid, they need to phone emergency services immediately, or you need to phone emergency services immediately. and also profuse sweating and agitation. That's the other presentation. I've actually, we talk about serotonin syndrome. I haven't really seen that much of it. I've only seen 2 cases of it, and none of them were in ecstasy users. Mm-hmm. But the key thing that really struck me was the agitation and the sweating. Have you seen serotonin syndrome?
I can't say that I have, Fergal. It's one of those things that we're so attuned to and we're aware of, but I haven't seen it in clinical practice yet, especially in the addiction medicine context. Mm. But it's certainly a great spiel that you've given us there in terms of harm reduction interventions. If we were to go through the acute management of some of the sequelae of MDMA intoxication, what would your approach be to someone in terms of how you would treat, say, hyperthermia or some of the neurological symptoms we've discussed?
So I think the management of this kind of intoxication problem is all about supportive management. So you need to actually go through your A, B, C, D, E, Fs. But, in particular, treating the problems of hyperthermia, you need to cool the patient appropriately. But, delirium, especially in the context of taking a pill at a rave, you need to do the blood tests and you need to actually identify hyponatremia. And if someone is hyponatremic, you need to correct hyponatremia, but not too quickly, because as you know, there is a complication associated with the over-rapid correction of hyponatremia. Would you care to talk to us about that?
Yes, Fergal. Rapid correction of hyponatremia can cause central pontine myelinolysis, and that can cause pontine dysfunction, and that can be a fatal condition. So you don't want to overcorrect in these situations. Mm.
But there's another condition. The other really dangerous issue that we need to talk about is the management of rhabdomyolysis. So first of all, Philippe, why do we get rhabdomyolysis and ecstasy toxicity, and then how do we treat rhabdo?
So rhabdomyolysis is muscle breakdown, and you get the muscle breakdown due to a combination of different things. You can get it through to the hyperthermia we talked about earlier, the muscle spasming, and kind of the increased metabolic rate that you get when you're using MDMA. So your cells are burning a lot of energy. So you get a lot of waste product, and you're burning a lot of energy. And when the kidneys are not functioning as well or can't clear the waste products as effectively as they usually do, this builds up. And this is a fatal condition. It can cause kidney damage, it can cause acute kidney damage, and it needs to be rectified and identified promptly. And this is something that unfortunately needs a hospital admission once you get to rhabdomyolysis. This is not something that can be treated in an outpatient setting.
No. And the management really is basically flushing the system, so it's saline diuresis. You need to give a lot of fluids to actually help the kidneys clear out the waste products or the byproducts of muscle breakdown. I describe rhabdomyolysis as the melting of muscles. And I think it's quite an appropriate description because, when you look at people who've had rhabdomyolysis, after if they've survived it and they've literally got no muscles, They've been hot, and then the next couple of days, they just don't have any muscle mass in their arms or their legs.
Indeed. And I guess what we've talked about now is some of the acute management steps of MDMA intoxication. But moving on to more stimulant withdrawal management, and by stimulant, we're talking about MDMA. We've talked about methamphetamine withdrawal in previous episodes, but say MDMA, cocaine, cathinone, and say bath salts, and let's lump them all as stimulants. What would you say is one of the hallmarks of withdrawal management for this grouping of substances, Fergal?
Well, I think in terms of the natural history, you end up with this, this almost like a major depressive episode. You end up with a time period where basically they stay in bed and they're very vegetative. All they do is eat and sleep. And actually the treatment for that phase of withdrawal is actually, in part, to actually make sure they eat enough and drink enough water to sustain themselves. And then you get this rebound awakening where they get very agitated. And that's the time when they really get antsy, and that's the time when they self-discharge. And then as time goes on, then you end up with this constant anhedonic craving for the drug, which then gradually over time gets better. And really, in the case of most stimulants, it can take up to a year to actually recover the ability to experience joy. And you've got to understand that ecstasy at high doses, ecstasy has been found, certainly in lab rats, to cause basically the scorching and burning of dopaminergic, serotonergic, and noradrenergic neurons. So, if you don't have the ability to produce these monoamines, you don't have then the ability to experience joy and love. So Indeed. It takes a while for the brain to regrow, and then and for you to relearn to experience these phenomena. So imagine going through a time when you're in withdrawal, when the only thing that makes you feel better is more of the drug, and yet you're joyless and you don't have any love. It would be. I have a lot of sympathy for people who find themselves in that position.
And I think you've highlighted a really important thing there, Fergal, where psychosocial interventions are the hallmark of withdrawal management for stimulant drugs. There is no pharmacotherapy option purely for stimulant medication, stimulant drugs, sorry. So it is that psychoeducation, the psychosocial interventions, cognitive behavioral therapy, acceptance commitment therapy, trying to identify the triggers for substance use and trying to ameliorate those triggers or try and redirect patients when they try and seek stimulant drugs. Would you say that's fair?
Yeah, I think we need to make a distinction between the treatment of the acute phase and the treatment of the medium to longer term. I think in the acute phase, it's perfectly reasonable to use symptomatic relief, which may include, controlled small to moderate doses of benzodiazepines for only a short time, whilst the patient's in the acute detox unit. So it's very common for us to use these, benzodiazepines such as diazepam to manage that rebound agitation that occurs when they wake up from their stimulant, during their stimulant detox. But then as we move into the second phase, the community phase, then as you say, really it is psychosocial. And you've mentioned acceptance and commitment therapy. I think that the best evidence for stimulant withdrawal management and recovery from stimulant misuse is actually it has been encapsulated in the matrix system. So in the matrix system, you have one-to-one psychological sessions, you have family therapy, you've got group therapies, and it's very, very intensive for the first 16 to 20 weeks, and then the intensity then gradually tails off. But there are a couple of techniques that are very useful in recovery from stimulants. And the first psychological technique is contingency management. And the second psychological technique is CBT. So, what is contingency management then, Philippe?
To put it crudely, contingency management is trying to create a reward system for performing behaviors that are seen as quote unquote acceptable. And by that, I mean, and I guess the best evidence for this is with methamphetamines. And I think we briefly touched on it in our episodes on methamphetamine. But say if someone has methamphetamine use disorder and the goal is abstinence, and the measure is urine drug screens, say for every urine drug screen that does not show the presence of methamphetamine metabolites, the person gets a voucher or a dollar sum of money or some other reward that has been predetermined or pre-accepted. So that's contingency management in a nutshell. It's rewarding patients or people for performing behaviors that we are seeking them to perform going forwards.
So another way of putting it is it's paying people to be clean.
I was trying to be less crude than that, using a lot more words, but that's exactly right.
Yeah. Now, this is a really interesting point, right? Let's say that we're trying to convince the commissioner of a service. Let's say that there's a body of money, that there's a commissioner who wants to pay a chunk of money for us to provide a service that's going to help people with stimulant use disorder who are in recovery. We then have to say to this person who's giving us this chunk of money that we're going to pay people to be clean. That sometimes is a very difficult message to get across. And there's a lot of there's a lot of incredulity when I talk about contingency management. And I think it's really important to make the following point. Contingency management has been proven to work in the management of stimulant use disorder and recovery therefrom. It has been proven to work. And it's also been proven to be better than any other pharmacotherapy. What would you say to that?
The evidence backs you up, Fergal. I've got no disagreement at all. Contingency management is an effective intervention. There are numerous studies. There is a lot of evidence that it works. So I don't disagree with you.
So it's very often combined with CBT, and I think that the combination of CBT and contingency management is great because contingency management, in my opinion, gets people clean, whereas CBT then keeps people clean. So you have this tail effect after appropriate CBT that you tend not to get with contingency management. Although it's not impossible to have the tail effect just with contingency management, but it's more usual to have the CBT effect longer lasting. So I think it's really useful to understand that the psychosocial interventions have to incorporate both contingency management and cognitive behavioral therapy, and discussions of the cycle of change and how we move through stages from pre-contemplation, contemplation, preparation, action, and then maintenance.
Indeed. So I guess in this episode of Cracking Addiction, we've covered quite a bit. We've talked about MDMA, the acute management of intoxication, withdrawal management interventions, and some relapse prevention strategies going forward. So thank you for your attention on this episode, and bye for now.